Introduce us.
This is Dr. Abbasi. I'm Amanda Armagost. You guys want to introduce yourselves?
I'm Ryan Buss.
I'm Koch.
So today we are going to talk about something that would be very important for lots of people who are in pain. Now, what are we talking about today?
Injections.
Injections. Now, these are not just a medication injection as like a medication that you get in your IV or IM. These are specific therapeutic injection we are going to talk about today. Dr. Koch, tell us a little about what overall this category of injections are called and what they are supposed to do.
Well, there are different reasons for getting different kinds of injections. So we have some injections which are diagnostic, which allow us to get a better sense of what exactly is causing the pain in the first place. Then we have injections that are therapeutic, which actually help the pain. The diagnostic ones actually help the pain too, but for a very short period of time, maybe an hour, 2 hours a day, something like that. I would say those are probably the two broader categories.
Yes.
Then you can also look at it in terms of categorizing peripheral joint injections, which would be things like shoulders and knees, versus spinal injections, which would be injections into the spine. Then you also have injections into muscle. There are joint injections and muscle injections. So, for example, there are trigger point injections. So there's a lot of different ways to categorize injections. I'm not exactly sure which one you're referring to.
Well, that's actually a very important distinction. First of all, we are not talking about like getting a medication in your IV for therapeutic, like effect of a medication itself in your systemic area. We're talking about for injections to certain musculoskeletal area for management of pain, and you very well classify them in diagnostic versus therapeutic. So Ryan, you're planning to go into medicine, right?
Yes, sir.
Tell us about what are you planning to do?
That's a great question. Now maybe surgery. I don't know if I can.
But you're planning to go to
I'm
med
not
school,
sure.
right?
Yes, sir. Yep.
So, when you hear the word therapeutic versus diagnostic injection, what does your brain tell you? This category? What do they mean?
Yeah. So I guess therapeutic injections would be some kind of an injection that is meant to actually alleviate pain or relieve symptoms that a patient might be having. I would imagine. And then diagnostic injections would be, ones that are just meant to either relieve pain for a really short period of time so that you can tell if that was the cause of the pain, or do something else like inject a dye or maybe some other diagnostic tool like that.
You're getting very hot. You're getting very warm. But Amanda, have you ever had an injection?
Not in that sense.
Not what? Have you ever had injection? Do you want to tell us?
Well, before the description of an injection, I would say my COVID shot.
Yeah, that is an injection. That is definitely an injection.
That's not the kind of injection we're talking about here.
No, well, injection generally is anytime you put a needle in a person and put a medication that's supposed to affect anything, that's obviously an injection. Now, Ryan, I have a question for you. What are those general areas that you put the medication in when you do an injection? Like, these generalized categories of where your needle supposed to end up.
Sure. I was just trying to remember this today.
Let's go from superficial to deep.
Okay. Intradermal, right? The first one?
So, intradermal, exactly. Okay. What kind of injection do we do intradermal? Very often we do that to...
Would that be like a Botox type thing, like a cosmetic
No, it's
one,
not. The Botox is not intradermal.
Okay.
But allergy tests are mostly intradermal,
okay.
Because most of your immune system is in that area that you put it there to see if your skin reacts to that. And if it doesn't, you don't have an allergy to that.
What about a tattoo?
Tattoo is actually that's a very, very good one.
Yeah.
It is not something we medicine do. I know it's something you're familiar with. It is, well, Dr. Koch, where is the ink of the tattoo? Where is it that it doesn't fall off?
I guess it's probably the dermis.
Not dermis. If it's, yeah, well, what is our skin? Our skin is made of layer of cells, and that cells regenerate and push everything above that will be exposed. It has to be subdermal. If it's below that level of regenerating cells, it's just going to be shed out. As a matter of fact, that's a trivia. Not many people know that there are some animals, they just live from what we shed out of our skin. That's their food source. So, and every person shed about, I heard, somewhere around 30 gram of dead skin every day. So add all the people around and 30 grams, like an ounce of dead skin every day. Every time you go to a spa and
I
rejuvenate,
don't want to think about it.
yeah, you force that. Actually, you do it much more. But that is
That's what exfoliating is.
Yeah.
that's exfoliating is. So let's. Do you want to talk about tattoo or injection?
Injection. But is a tattoo an injection?
It is. It is in a way. You put, but not a medical injection.
Yeah.
I'm not gonna learn that in medical school.
No, I don't believe so. Neither will you learn acupuncture,
Okay.
which is not an injection per se, but it is a needle that's supposed to do. The needle itself is supposed to do something. There are lots of other things that we put a needle in people that we burn something. We may talk about that. Not originally it's an injection, but that we deliver electricity to do a job there. So, top to bottom, surface deep, intradermal, sub-Q or subcutaneous, subdermal injection. What do you know a medication that we give sub-Q or sub-epidermal? Lots of people have that problem. Oh, Amanda
I
knows
know
that.
it. Mhm.
Okay,
I don't know.
take it, Amanda.
Is it insulin?
Absolutely,
Okay.
absolutely, insulin.
Nice.
Yeah, or insulin-like medication. Heparin, yeah. Now, what other medication? Let's go a layer deeper yet. What is under the skin? Most of the time is fat, but we don't put really any medication in the fat. But what comes below the fat?
Musculature.
Musculature. So intramuscular injection. Now we are getting close to what we really want to talk about. So, Dr. Koch, take over. First of all, when you do a muscular we call it intramuscular, or abbreviation for that is IM, exactly, intramuscular injection. Where do you try to be? What do you have to pay attention? And when does it fit when you're trying to do a therapeutic injection there?
Yeah, I think it probably depends on the application. I've never given, for example, a flu shot, which is IM, but I'm guessing that they want to go for where there's the most bulk of the muscle. But definitely when I do an EMG study, which is not an injection, but you do have to stick the needle into the muscle, you actually look for the bulkiest part of the muscle. There's specific landmarks, but you end up going for the bulkiest part. Which some muscles is very difficult because, for example, these are called the interosseous muscles over here, and sometimes we have to go in there, which you can't really see anything. You just kind of have to stick it in here. It's one of the very painful places to go.
Yeah.
But when I'm doing trigger point injections, which are also intramuscular.
Since you talked about the EMG thing, I'm going to tell you a secret. That secret is that even if you do EMG, electromyogram, or you get a patient that even in skinniest patient, how much fat do we have? About the centimeter. This most skinniest person on planet probably have about half a centimeter fat, and on top of that comes half a centimeter dermis. How long are your needle?
The EMG needles?
Yeah, how long are they?
We have different sizes, but they can be short.
Generally.
An inch is probably the shortest one we use.
Yeah.
1 to 3 inches.
What I'm getting at, those needles that we do that all the time in my surgeries, with needle that we use, they're about a centimeter and half an inch. You don't need to be in the muscle to get the electrical activity of the muscle. The same way, you don't need to be in heart to have EKG, right? Where do you gather the EKG information? From the skin. And how far is it from the heart? A lot. And you still get the electrical activity of the heart beautifully. We have been doing it for almost more than 100 years, very
So I
effectively.
think you're talking about the difference between surface electrodes versus needle electrodes.
No, but even needle electrode, you break the barrier under the skin where the most of the resistance in getting any information of the electrical activity out of the body is the skin. When you go underneath, you get a much better connection or reading, but you don't have to be in the muscle to get EMG now. You can get like if you really want to get the difference between those intrinsic and very fine muscle, then you want to be as close to the muscle so not to get the signal of the other muscle. But generally, once you break the barrier, which is the most electric barrier in our body, is our skin, then you just get a better breathing of that. So, try to speak what?
You're okay. It wasn't even about.
Okay, so
You're
Now-
the only one out of all of us who's doing a good job.
okay. So let's talk about intramuscular
Yes.
injections, and when do you use it for therapeutic purpose?
Yeah. So
Again, not giving a muscle injection like flu shot and so on, but truly musculoskeletal injection in a therapeutic sense.
So we know of something that exists called trigger points within muscles. The exact mechanism of what makes them happen, there's at least two different hypotheses.
Mhm.
Some people say it's an overactive muscle spindle, which then causes the muscle to be continually contracted. Some people say it's an area of hyper excitable muscle where you have the neurotransmitter that makes a muscle contract, which is called acetylcholine. Normally, you have small little doses of acetylcholine even when a muscle.
So you have pain in the muscle
You can have pain, yes.
or a
Yes.
spasm in the muscle.
Yes, correct.
And that is when you have a pain or spasm in the muscle, is that so you want to break whatever mechanism is producing that. And you're describing very nicely, actually, what those two mechanisms are, which is way above
Yeah,
head
too
of
much,
lots of
sorry.
people. No,
Yeah.
you're fine. I think there will be lots of
That's
med students and so on that will be enjoying that.
I
So-
think the average person just calls it a knot. You have a knot, it's like a sore part of your muscle, and if you press on it, sometimes the pain radiates around that point. So that's a trigger point. And so we can definitely use, now there's actually two different techniques. One technique which a lot of physical therapists use to break a trigger point is called dry needling.
Okay.
And dry needling, they stick a needle in, but they don't inject anything. And the mechanical action of the needle going in and out of the muscle tends to break apart the muscle. What we can do as physicians is we can also have lidocaine, which is a numbing agent that we can put in. So in addition to breaking up the muscle with the needle, we then can inject the lidocaine, and that's been shown to actually give much better response right after the injection. In other words, a lot less pain right afterwards. So the breaking of the muscle, even though that's good in the long term, in the short term that can cause pain. But if you inject the lidocaine, then you don't really feel the pain.
Now, just to now give a little background to that is that now how does our muscle know, Ryan? How does our muscle know that it has contracted enough and it shouldn't contract more? How does your muscle know that?
That's a great question. Maybe something to do with the mechanism of the, what is it, myosin or whatever in the cells? In
No,
the
it's
muscle
actually
fibers?
it's an active process. Like how do you know I'm sitting here? You see me.
Uh-huh.
There's a sensory. There's something that
Yeah.
gives your brain the information that somebody shaped like me is sitting here. How do you know the table is there? You feel it, and the nerve get the information, bring it to your spinal cord, bring it up to your brain. Now, the muscle has its own regulation system. Now, what do I'm not going to ask you, Amanda. You're just here to bring us back to the
To the point, yeah.
to the point that people understand what we're doing. So there are two mechanisms our muscle knows how to regulate how much pressure to put there. Like, how do you know that you press a egg and you don't break it? You know how much pressure you are providing. How do you know how much pressure and not more you're providing there? Some of our muscle cells, they change their nature. They turn into something that actually give a signal back to our spinal cord. Coach, do you know how we call them?
Well, there are two things.
The muscle, the one that is in
Cannabis,
muscle.
So that's the muscle spindle.
Muscle spindle, exactly.
So the muscle spindle detects the length of the muscle and also the rate of change of the length of the muscle.
Yeah.
And it gives that information back to the brain through the spinal cord.
What is the other sensory system in our muscle group that gives information about what the situation with our muscles
So
is?
there's something called the Golgi tendon organ, which is responsible for monitoring the amount of pressure or force that the muscle is generating.
So these two sensory, they're like your eyes. They're like your, like they give you information of actually what is going on in your muscle. So this is the active process. Now, interesting part is actually they don't even go to brain. This is so crucial for survival. This is all get regulated at the segmental level in our spinal cord, that it inhibits or activates. Like, if you go to total spasm, you can break your own bones. Did you know that? That if you uncontrolled go to spasm, you can separate your tendon or break your bone. Our muscles are much stronger. That is, in a way, everybody's a Superman, because your muscle can do things that your bone cannot hold up with them. But we never get there because we have this, and this is survival for us not to get there. And that gets regulated, that if the feedback goes, it says, enough, don't do anymore. Now, if you get that out of the way, then that enough never comes, and then muscle can go to spasm, and then that's extremely painful, and they should be painful. So you know what you do when you have a huge muscle spasm, you stretch that muscle. By stretching that muscle, you lengthen the muscle spindle, trying to break that loop. Okay?
If you've ever seen someone, you can actually see them in action too. If you've ever seen someone nodding to sleep and their head starts to go down and they suddenly snap back up, that's actually the muscle spindle. When it starts to fall, the speed of the muscle lengthening is too much. And so the spindle says, oh, we have to send this signal really to the spinal cord. Then it's a signal sent back to get the muscle to contract. So first the head goes down, then it says, oh, if you keep going, you might rip the muscle. So I'm going to have to go like this. So you snap right back. That's the muscle spindle.
Every muscle has a reflex. And those reflexes are quantified and qualified, different reflexes and so on. But every muscle has that, because without that, muscle couldn't work. Knee-jerk reflex,
Knee-jerk reaction,
or Achilles tendon reflex, or what you just described. Babies have that. You drop a baby, then and so on. All of that has something to do that our muscle have to be controlled within certain areas. And so if you have a muscle spasm, you do trigger point injection. If you have muscular pain does not need necessarily to be a spasm, right?
No, yeah, you can have a myalgia, which is not spasm.
Yeah. Now, this trigger point injection, well, what does the name, when you hear trigger point, what does that imply to you, Amanda?
the point that causes the reaction.
Triggers
Trigger.
pain.
Yeah.
Yeah, the point that, now, how would you suggest we find the point that the point that triggers the pain, Amanda? No, that is a question for layperson.
I think
You show
by
us.
pressing it.
You tell
Touching
us.
it.
Now, Dr. Koch, you remember? I'm not sure if you and I were there, but tell us, how do you determine the trigger point in a patient who comes to you as musculoskeletal pain and you're anticipating injection? How do you determine that location?
So part of the physical exam is the palpatory part of the exam, where you literally feel the patient, and you can actually feel a trigger point. Ryan's in decent shape here. That might be right there. Is this tender right here, right?
Not yet, but yeah, I'm sure it will be.
If
They have a knot in their back,
Yeah.
if they slept poorly, and then you can feel it.
Yep, you can feel it, and when I'm touching the patient, also they can feel it.
Yeah.
And it's painful.
Surprisingly, they can localize it. We call that localization. Patient can localize it pretty well. You just put your finger up or down, right or left, and then more or less you go to that point. Now you found the place. What do you do with it, Dr. Koch?
So it depends. So actually, there are different ways of handling it. Some involving the needle and some not. There's a technique called strain counter strain, where actually, if you put the muscle into a passively into a shortened position. So in other words, I'm not having the patient contract. I'm going to put the patient in a position where the muscle is shorter, which is a more relaxed position normally. Then you can literally press it, and if you press for about 90 seconds, sometimes you can actually feel it kind of falling apart a little bit. The thing about that's kind of hard work on the operator. So the physician who's doing it has to have strong fingers, whereas with the needle it's just quick and easy. But that is one way of doing it for sure.
What about injections, though?
So the injection,
Is that something like that you would go see a massage therapist for, and then a massage therapist would do that, or
you're nice to your significant other, and
especially if you're married to a doctor. But they sometimes know those techniques, but more like an osteopathic doctor would know those techniques, DO, and some MDs as well know those techniques. It's pretty interesting that you can actually, without even breaking the skin, sometimes you can give a person relief just in that 90 seconds. So I had a lady that I was giving trigger points to, but we sort of had run out of lidocaine for the moment. And she said, but I still have pain on the other side of my neck. And so I felt it, and I felt the trigger point, and I did exactly that. I moved her neck so that she was comfortable and slightly turned. I kind of went in 90 seconds. I said, how do you feel now? And she said, oh my God, there's no pain. So, those are the days when it just makes me happy to be a doctor. They came in pain, and I sent them home with no pain.
Yeah.
And of course,
just by laying hand on.
Just by laying hand. But of course, I also told them, we can't, you have to be honest with the patient. Both trigger points and these kind of manual techniques are fairly short acting. I mean,
so are local anesthetic, right?
Well, sure, because the trigger point is the same thing. The trigger point is a local anesthetic. So yeah, it's short acting. I'm happy if a person says to me it lasts for 4 days, which a couple of patients did. I was surprised. 4 days they got relief after a trigger point injection. So that's great. But the osteopathic stuff, these manipulation techniques, they might, especially in the beginning, when the muscle's used to being contracted, it wants to come back to that place.
Yeah.
So in the beginning, it might last a few hours or maybe a day or something like that. So they're short term. Steroids injections last a lot longer. The reason for that is interesting. Brian and I were talking about this today. A steroid won't start taking effect until a few days. The reason for that is that the molecule of the steroid actually has to go through the way a lot of medicines work is they go to the cell, the surface of the cell, and they do their business on a receptor on the surface of the cell. And those kind of medications take effect pretty quickly. Some medications, like steroids and some vitamins, like vitamin D, for example, they actually go through the cell membrane into the nucleus, through the membrane of the nucleus into the DNA, and they turn on genes in the DNA to produce the proteins that are going to be the things that are necessary to do what they do. That process takes time. So a steroid injection won't even start working for a couple of days, and then usually, depending on where you're injecting, it can last weeks to months. But it's a longer acting thing, and it takes longer to start acting.
Now, that is a very good description about why steroids start working later and last longer. But what are steroids, Brian? What are steroids?
Again, that's a great question. I don't know if I know the exact definition, but they're a type of hormone, right? Made from cholesterol, or
very well.
From
Yeah. Now, there's a category, lots of other hormones that are coming from the same category. Nature tries everything again and again and add a little and so on. Do you know what other hormones of the same category are made of cholesterol? All the sexual hormones.
I didn't know that is. Oh, okay.
All the sexual hormones. Yeah.
Okay.
All of them. Okay. Now, specific thing about the steroids are, these are what we call the modulators. That means they don't work, as you said, themselves, but they modulate a lot of different pathways. But what are they supposed to do? Like, what happens if I take every single steroid out of your body? Or if you have a disease that steroids are not produced, there's a disease. Do you know the name of that disease?
I do not.
It's there's one called, I think, Addison's.
Addison.
Is one example. But there are also other things that you're born with where you can't go through the whole.
No, let's talk about the most common thing, Addison disease. are the patient with Addison disease?
So they have hypoactive metabolism. So
Okay, let's go to
Slower
that
down.
thing.
let's go for that.
There's something.
Hypoactive means like slower down.
It's slower down. Yeah,
Yeah.
exactly. Yeah,
So let's go with that. Let's go to the maximum damage. What is the Addison crisis?
So
Obviously, it's a crisis.
yes, it is a crisis. Going back to my med school days now, but I think you have low blood pressure, very low blood pressure. I think you kind of crash. That
You
way,
die.
And you can die.
You die. Addison crisis is an emergency,
Yeah.
and the
What
emergency
happens before then? Before you die?
before you die,
Yeah.
you're practically your system cannot regulate your fluids. Your system, that is one of the big mysteries. Steroids, they do so many different works in our body that you cannot really pinpoint one thing, but you cardiovascularly you shut down. Okay, you cannot manage your fluid in your body, and that is the magic of steroid. They do like thousands of things in our body, each of them vital for us. But if you in a morbus Addison or in an Addison crisis where all of a sudden accidentally or somehow you lose your suprarenal kind of thing, damage or accident, and you don't produce that enough of that, you literally to go to cardiovascular shock within hours and you die.
Now that we're talking about it and remembering more about it, what it is, that's exactly right. And what it is that when your body is working appropriately, you have things like cortisol and other sort of steroid type hormones like that actually can go and control things like keeping the tone in your arteries intact, so that the muscle, so that the blood goes through and the muscles can contract and it can push the blood through. Things like that. And then when you have this a lack of, so that's caused, you have things like norepinephrine is another one, all things that are coming from the adrenal glands. When you have Addison disease and your adrenal glands are impacted, suddenly you can't regulate any of that stuff. All the things that you would normally do in a fight or flight type of situation, for example, your eyes dilating, things like that, being able to shunt blood to the parts of your body that need it, that all goes away. Suddenly, and that's why you go into cardiovascular shock, because your arteries become limp and they can't get the blood and the oxygen to where it has to go, to the muscles to do the things that they have to do. Can't even really do much leaving the heart. So at that point, yeah. I mean,
That is like a magic in the ER. If you recognize it, you give them a little bit of a steroid, they stand up and they walk away. And so, but we are getting a little away from what we are doing here. Now, steroid. They are very effective to manage lots of different problems in our body because they work as anti-inflammatory kind of agent. They reduce the amount of inflammation going on, but why our body producing steroid all the time? Why is it we have a hormone that reduces the inflammation in our body? Why is it important? And the answer to that is that too much inflammation is a reaction to any agent that would cause damage in us. But our body has to regulate. Obviously, you want to fight those agents, but if you fight too much, that is one of those things that, fighting too much can cause harm for the person. And so they are anti-inflammatory. As a matter of fact, we have a different category of medication. We call them non-steroidal anti-inflammatory because we discovered them second. First, we discovered the regular anti-inflammatory, which are the steroids. So they have been in use for 150 years, and we used to take them from some organs of some dead animals. We don't do that anymore. We have a lot of knowledge about how they are used and so on, and they work. Still to this date, one of the major part of almost any therapeutic injection that we put in your body are steroids. Now, we have better steroids. We are not going to be able to go to the depth of it.
We should even maybe have a podcast about steroids.
Yes.
Yeah. What's the
I
next?
think,
What's the next level of injection? Like the next.
Well, let's talk about the
step.
injection. So we went from the subdermal, subcutaneous, intramuscular. What is it when we go in our body deeper? for the therapeutic purpose, what is the next level? Joints. Okay? Almost in every joint that you can imagine, there can be an inflammatory process that you can put a needle in and you can put steroid in. Most of the time when we put a steroid in, we want it to last longer. So, Dr. Koch, what is our tool to make the steroid stick there longer? That like doesn't just come in and out.
Well, we have to make sure it's in the joint capsule.
Yeah, no, but I'm talking about you are in the right place, but you can put medication that get in and out faster than medication that goes in and out slower. And obviously we want to have a longer lasting effect. As a matter of fact, we may want to have a longer lasting effect or not. But if we decide for that effect to last longer, what kind of steroid do we use?
Oh, I see what you're saying.
Yes.
Yeah, so they're different, right? So different steroids have different lengths of action.
How do we call that? Ryan, how do we call the time that the medication, whatever medication, has a reasonable effect in our body?
Like,
it's not radioactive,
yeah.
but they use the same term.
So like a half-life then?
Half-life.
Okay. Interesting.
So some medication, what kind of steroid have the longest half-life?
I think methylprednisolone.
It doesn't have to do with the medication itself.
Oh,
It's a physical characteristic of a medication. We call that particulate.
right. So if it's particulate, it has a longer half-life than if it's non-particulate.
What would that be used for?
No, but what is particulate versus? What do you understand, Amanda? What's a particulate?
That lasts longer.
No, but what does that mean? Like particulate versus non-particulate? Like imagine you have the same medication. One is just the emulsion or just a bland, all solved in a solution. The other one is particulate. What do you understand under that? That there are small little, like, even macroscopic amount, like grain of sand of that medication, much smaller than grain of sand. But it is not all in the fluid. It is a solid part of that medication. As a matter of fact, when we get that, we have to shake it. And then when you don't shake it, it's like you can see through. But if you shake it, it becomes white because those little particles, they reflect. Yeah, they're floating around and they reflect the light. Now, so and I like to use them because they last longer for many of my injections. So in a joint, you can put those medication, mostly a steroid, but as well you can numb it up. Numbing up has a short lifespan, but it can bridge the time until the steroids start truly working. Okay, so now talking about the joint, our spine has a lots of joints. Dr. Koch, what are the joints in the spine or joint around the spine that we inject? Obviously,
So there are facet joints, for example.
Facet joints are. Misha, can you get us a spine model, maybe from outside? Now, so tell us about the facet joint.
So the facet joint is where the top part of one vertebra and the bottom. Should I get technical or anything?
Well, you go
The
as
top part of
technical
one-
as you
I'll say
want.
that.
We have Amanda helping us to.
That's true. The bottom part of one vertebra sticks up, and the top part, the bottom is easier to show.
So practically, we're going to walk in
Yeah, God.
and do a little spinal anatomy.
Here we go.
So in me right now, my spine is like that. In the back of my spine, there are where two bones are meeting. Where these two bones meet on each side, there is a
Hey.
small little joint.
Maybe put the mic.
A small little joint. And this small little joint in the back is what we call facet. Now, next to the spine, this joint here, or if you look from the front, this joint here, we call that iliac joint. Now, additional to this joint, once you go one time deeper, you get into where the nerve is coming out. We call that, what do we call this whole nerve?
Is that the nerve root foramen or?
Foramen.
Okay.
The foramen. We can put some medication there. We call that intraforaminal injection, or this is the nerve root or nerve root injection. We can numb up this joint here. We call that facet injection, and we can actually, instead of numbing the joint itself, we can put the needle out here where the nerve is, which goes to the facet. So that Coach, if we numb up or put the medication in the facet, we call it facet injection. But what if we numb up the nerve that goes to facet?
And we call that a medial branch block.
Medial branch block. That's called medial branch block, and it works actually better than the facet injection itself. It gets us directly to the nerve that cool it down and reduce the inflammation. Now, imagine we go deeper than the here. Here's the here. Imagine we go deeper. We go into the hole inside where right there in that hole where the spinal cord is, but we don't enter the spinal cord yet. Brian are going to go to medicine. You have to sweat here.
Okay.
What is the name of that space between the bone and spinal cord?
The central spinal canal, or
No, the space between the spinal cord
Okay.
and the bone or membrane. The spinal cord has a membrane around it. It's called dura,
okay,
right?
right.
Now, the space between the dura and the bone, how do we call that space?
The epidural space then.
That's the epidural space.
Okay.
And that's the next deeper space where you put the medication. That's called lumbar, thoracic, or cervical epidural steroid injection.
So would you want a longer lasting or a shorter lasting steroid injection?
And generally, I always want to have longer lasting injection.
In what case would you want a shorter lasting injection?
In a specific cases that you have a massive kind of inflammation there, that you want to treat that like right now. But for most of the therapeutic injection, I do prefer longer lasting particulate matter. Having said that, that is the so-called epidural steroid injection. Depending on the location, we call it cervical, thoracic, lumbar epidural steroid injection. Now, we can go even one level deeper. What would that be? I don't believe you will get that. Amanda, you are at the risk of getting that doing something that lots of women go through. But it's something lots of women go through and men don't. Birth. Yeah, exactly. Have you heard that some of the women, they get the spinal?
Yeah. And isn't that an epidural?
No.
Even
That
worse?
That is not worse, better.
More intense?
It actually goes inside of the spinal canal, that just next to the spinal cord and the nerves are inside.
I thought that was an epidural too.
No,
Yeah,
it
They,
is
they
not.
can get epidurals, but that's different area.
More intense level.
Well, that is called spinal anesthesia. You can do surgery. You can numb it up. We can do knee surgeries by putting a needle there, constantly give a little bit of a local anesthetic, numb up all those nerves. And if you don't feel those nerves, for your brain, they don't exist. So you
Pain
can,
is in the brain.
at the end of the day, all the pain is in the brain, in our head, okay? So, but you can do surgery. And a woman can give birth. Interestingly, many of the mechanism of giving birth is not controlled by the same pathways where the pain goes through, meaning that you can just go through the process of birth without feeling that horrible pain. You can do some, but not all abdominal surgeries as well with spinal. What is the problem? Why don't we do that for everybody? Obviously, we do that because it is safer than general anesthesia in many regards. But why can we not do spinal anesthesia or spinal blocks, they call it, for things on the arm and hands and so on? Why can we not do that?
I don't know. That's a good question.
If the anesthetic gets to brainstem, meaning C5, 4, 3, and above, it numbs up those areas that are responsible, make you breathe.
Oh.
Quit breathe, and you die. That is why you have to pay attention. Okay, so
Yeah.
but they're very effective in many areas. So we went all the way from outside to inside. I don't believe we have enough time to go through lots of more, discussion about the details. There are so many more, but I don't believe that. Every time we do a podcast, Dr. Koch and Amanda and Ryan, we come up with so many different
Yeah.
subjects for the next time. We never run out of subjects because medicine is a deep matter and our knowledge is vast, but that even is just a fraction of what we know, and every answer provokes more questions. So,
Yeah, I actually do
What
have
question do you
one
have?
other injection question.
yeah,
Actually, I have two. So one is for you. I think that sometimes you inject patients with a dye to see something that's going on in their spine.
hmm
Can you maybe go into a little bit
absolutely,
more detail?
absolutely. Now, when we get X-rays, there are certain things we see, like bone, like metal. But how do I know if I'm in the right place if it's not the bone and or metal, but it's soft tissue? The X-ray alone is not good enough to differentiate where you are. Whereas between those tissues, there are always layers. I fill those layers with something that X-ray cannot pass through, so it gives me a dark spot there, a shadow, so to say, a contrast, and I enhance the imaging by putting the contrast material in. Then I know in which soft layer I am. Am I between the muscle and the bone, or am I below the bone? Am I in the space between the dura and the bone, in the epidural space, or am I intradural? Well, if I'm not planning to do a spinal anesthesia, and I'm not in the epidural space, but in that area, a patient just start losing all the function in the legs right there. Well, most of the time it comes back after a few hours and so on. But I really want to know if I'm in the intrathecal, which is inside of the dura, or in the epidural space. Okay. So, Dr. Coach, to top it off, what do you do if you want to do an epidural injection, but you accidentally end up to be in the intrathecal or inside of the dura? How do you recognize it and what do you do? Because this may happen.
Yeah, it may happen. So you can get a cerebrospinal fluid leak coming out in that situation.
No, well, no, you can get a leak either way. But what about if you get your medication instead of in the epidural space, in the intrathecal space?
What medication is it?
Well, what do you do for
It's
local?
another medication.
Here we are. No, well, here we are. We are injecting what? The steroids and local anesthetic. You get the medication in the intrathecal space. What happens? How do you recognize it? What do you do?
I'm actually not sure.
And let me explain. The steroid part is harmless. Okay? Steroids are, in all our thing, it reduces. Sometimes we do steroid intrathecally for certain situations and so on. The anesthetic part is what practically shut down all your nerves. That's what it's supposed to do, and it does it very well. The good news for you is if you're doing a lumbar epidural, whatever you put in is heavier than CSF, cerebrospinal fluid. First of all, you notice it because patient says, "Doctor, I have a jolt going down my leg, and I don't feel them anymore. I don't feel them. I'm freaking out. I cannot move my legs. Am I going to die?" No, you notice that. It may take a few seconds, but practically immediately they lose all function. The most important thing you do there is bring the back of the head up, because you don't want that material to move up. You want them to move down. You put them in a wheelchair. You observe them. Most of the time, you send them to a ER or to a hospital. You admit them to the hospital. You make sure they don't put their head down. You hydrate them. Why do you hydrate them? To wash it away. More fluid in and out, shorter half-life. And then you just do supportive measures until that goes through their system. Now, what is the half-life of lidocaine, one of the anesthetic we give? About an hour or so. But many times we give bupivacaine. Dentists give bupivacaine. What is the half-life of bupivacaine? 4 to 6 hours. Yeah, 4 to 6 hours. So meaning that it takes about half a day for the effect to go away. And you just support them and make sure that they don't put the head of the bed down. Okay. Now, what if that happens in the cervical spine? You better have your crash cart ready. Why? We talked about that.
Because then you can't breathe.
They quit breathing. What do you do then? You bag them, you intubate them, you call 911. But you bag them and intubate them as soon as you keep the head up. As soon as they have difficulty breathing, you need to start bagging and have your crash cart ready to intubate. Okay?
Awesome.
Yeah. What happens, though, if you're that unlucky, you get lots of, especially lidocaine, into the subarachnoid space around your brain. I hope you never see that because patients go to seizure. Okay? They can't breathe and they're in a seizure. What that means, try to intubate somebody who cannot breathe but is in seizure. Yeah. So,
How do you stop the seizing?
well, Dr. Koch, how do you stop the seizure?
I assume
I'm a
you stop
neurosurgeon.
it. Yeah.
I know that.
Yeah.
But how do you stop the seizure?
I'm assuming you do this thing you always do to stop seizures. You try to somehow get some benzo in there. It could be Ativan, it could be barbiturates, something like that. These are all anti-seizure medications that you use acutely when someone is seizing.
And that is why Valium is in every crash cart.
Can that be injected?
Yes.
Yes,
You
it
can
has to
inject
be.
that?
It has
It
to
has
be.
to be. Yeah, because you can't force somebody to swallow.
Well, they can't even. They're seizing,
Yeah.
so they can't. Yeah.
Yeah. Okay.
They're passed out. They cannot swallow. So I hope nobody who's listening to that will ever see that. I think it is 5:14. I think we covered a lot. And I think there are 10 other things that we still haven't covered and we can cover next visit. It's Friday, 5:14. People are starting their weekend.
Yeah.
I'm Dr. Abbasi.
Thanks, guys, for watching. I'm Amanda. Don't forget next week to come and watch our case review.
I'm Ryan.
Coach.
And welcome to Essence of Medicine. All you need to know about injections. Thank you.